HIV-2 viral load under the impact of HIV-1 wiping out those cells that HIV-2 could otherwise potentially infect and use if it were not so slow. So it's really HIV-1 that drives that picture, and that's certainly what I saw clinically. Although those people have to be treated, of course, with a boosted protease inhibitor regimen, because you can't just treat their HIV-1 and let their HIV-2 develop resistance and wait.
My provocative question would be, do you really need to treat HIV-2?
So it's true that HIV-2 is a slower disease, and a much larger proportion of individuals, perhaps a third, may have essentially no disease progression. And yet it's those other people, the other two-thirds, that I think need to be getting care. In particular, the 10 or 20%, well, let me be a little fuzzy about the numbers, but that minority which has progressive disease, they will simply go on to AIDS and die without care. But there's a large number of people who have slow disease, and you see them with their CD4 counts of 300. They're not quite normal, but they're not just about to die. And this, in the setting where you have to decide on who gets care, we apply certain thresholds. In the Gambia, we were using a CD4 count threshold for who got care and who could wait while we dealt with the others. In those settings where that kind of a rule still applies, one could make the argument that if HIV-2 is a slowly progressive disease, we can sit on our hands for a while and treat other people and let those people trickle on down to a more vulnerable level. But I think that that's risky, because while we show that after 2 years their immune reconstitution is essentially equivalent, most studies looking at CD4 recovery, immune reconstitution in HIV-2, shows that it's not nearly as good as those people infected with HIV-1. And so you can't let them go as low if you expect to bring them back up to a safe level.
My last question is regarding an aspect of the diagnosis of HIV. You mentioned somewhere in the text that you expected the patients to have 2 visits. And my question, why do you require 2 visits for the diagnosis? And you also mentioned there was a high rate of false negatives. Why was that? In the context of the clinic that you were conducting at the time.
The false negatives came up when we were trying to do point-of-care testing. So we tested the point-of-care tests in our laboratory. We tested them against our standard laboratory procedure. We tested them in the clinic with all laboratory personnel. And when all of that seemed to go well, we tested them in the clinic with one of our medical assistants who had been trained by the laboratory personnel. And in that last step, we saw that there were false negatives, people who had HIV and were sent home being told that they didn't. And so that was simply unacceptable. So we had to stop our point-of-care testing, but I think that was idiosyncratic.
Just methodology, local methodology.
That's what
people who are not trained enough.
This is my conclusion. The making people come back on a separate visit for a separate blood draw in order to get a comparison was a point that I argued with our serology lab head on a number of occasions, but she's pointed out that if you make a mistake with the identification of the person at one point in time, and you've based all of your studies on that one point in time, then you're done. And mistakes happen. So it was less convenient for patients. It delayed diagnosis and treatment. it ensured the identity of the people and connecting the right diagnosis to the right person a little bit more. I probably wouldn't recommend it.
Okay. This answered my questions. Does the promoter have any questions? Since this is a public defense, I turn to the public to ask if you have any questions for Dr. Peterson. Zijn er vragen? Yes, just a minute. I will bring the microphone.
My question is about the standards of care for HIV in the Gambia and how it has progressed over time. When you were there, you were saying that basically you were triaging people based on the level of their CD4 as to whether to treat them or to wait. In the time that you were there, were the thresholds raised, and have they continued to rise over time?
Those thresholds were raised. We were initially afraid that people would line up in front of the doors of our 3 clinics where we were providing antiretroviral therapy, and we would be overwhelmed. That didn't happen. We were, I think, a little slow to adapt to that and relax the threshold, but we could have moved faster. But we moved fairly quickly to what was at the time considered a fairly progressive standard of a CD4 count of 350. I recall speaking with Professor McAdam in Uganda, and we were talking about, at that time, the WHO shifting its threshold from 200 to 350. We were somewhat ahead of the WHO in Gambia, and Professor McAdam said, our people are brought in on stretchers. We don't have a lot of people with CD4 counts over 200. We have a hospital next to us that has sick people, and they get diagnosed. I had an STI clinic with largely asymptomatic people. So the difference between a low threshold or a high threshold mattered for me in being able to provide services. I believe that the 350 threshold has not been changed in the Gambia. I think that the future of HIV care for Africa as well as everywhere else is to test and treat, maybe with a comma. Test, okay, treat. Not to immediately rush into things, but to not delay treatment simply waiting for people to show a predetermined threshold of immune insufficiency.
Any other questions from the public? Andere vragen?
Yeah, thank you. I have 2 questions actually, if that's allowed. One is about the screening tool for depression and post-traumatic stress disorder. The studies that you did showed a very high prevalence of both, but this was both in HIV-infected people, and I was wondering what would be the case in a normal non-HIV infected population, because these tools are obviously not developed in the Gambia.
Indeed. I'll answer that question before you ask your second one. We did this study, and that was the immediate question. Okay, where do we do our next study? Can we look at this for HIV-negative hospitalized patients? Can we look at this for ambulatory patients in our clinic? Can we do this for people, use this for people presenting for psychiatric care in Banjul, the capital? And can we see, does this tool give reasonable information in these different settings, and do we see a difference? There was extremely little animo for doing any of those other studies. And I said, I'm an HIV doc and my plate is full. I think these are really valuable and I'll help, but I'm not going to run this study. And nobody else was interested.
Well, that's a pity because it matters for the interpretation of those prevalences. My other question is about the response of the CD4 count in people who start antiretroviral therapy. And you showed this very nice graph where both in HIV1 and HIV2 there is an increase, and it goes up in time, over time. But very striking is that this response is less in HIV2 than in HIV1 infected patients. And you rightly quote other papers from other treating cohorts that have found the same. But I was wondering what you think is the real explanation for this odd observation.
I believe that what's going on there is that these people have been infected for longer. In general, they have lower viral loads. Before you see them at point X, they've been carrying their virus for a lot longer. And I think that their thymic progenitor cells have been more affected. So they're not ready to turn around and start making the CD4 cells. They need to, in a sense, replenish their progenitor cells first before they're able to pick up speed. And that is an elegant verbal explanation for the results of that graph that I had up, which I can bring up. If it's true or not, I don't know.
Professor Macaron has another question, remark.
I'm struck by the fact that you say there are 23 million people living with HIV in Africa. And in 10 years' time, every one of those should be on antiretrovirals. And there aren't the workers. So you talk about task shifting. But to what extent have you used the 21 million who have the virus as the means of task shifting, so that they become the champions, the change agents for their society, rather than expecting medically qualified people to do that job?
That's a good question. In the Gambia, we had support societies, and at some point there was interest in creating a role for those individuals to do counseling in the context of clinical care at our clinic and at other clinics. We opted not to do that. There's something of a room shortage. We had staff. I thought it was a good idea. It wasn't necessarily what we needed to do at MRC at that time. There are certainly centers, I will mispronounce it, but Kailishita, where's Chris? Thanks. Who really built their model on this kind of a system for adherence support. I think that's brilliant. There is at some level where I think we're dealing with people with a disease and we're treating it with medicines, and with task shifting has to be an avenue to move people up in the care network for where their issues are not clearly being resolved or able to be resolved on the ground. But I think the role of peer counselors for adherence support is a great opportunity to get some of those people actively engaged in putting an end to this problem. It is a little daunting thinking about 15 to 20 million more people in a short period of time. And we will inevitably be facing issues of antiretroviral resistance, and that's going to increase the costs of care and increase the technical challenges of providing care.
Any other questions or remarks from the public? Andere vragen van het publiek? Zo niet. Then we finished question time now, so the jury will withdraw now for deliberation. They don't go away because we will be back.